I think we're going to start right now. Okay, we are live streaming. So welcome. This is the Senior Issues, Housing, Health, and Welfare Committee of Community Board 10 in Brooklyn. I'm Iris Muley. I'm chair of the committee. And I welcome you to tonight's meeting, which is an opioid use disorder forum. So we're very pleased to have Dr. Anthony Accurso with us. Accurso, I'm sorry, I just destroyed your name.
Perfect, Accurso.
Accurso. Dr. Accurso is the medical director of program development, and he's assistant professor at NYU Langone Health. He will be presenting some important information to us this evening. After his presentation, we will open it up to questions from board members, and then we will open it up to the community as well. Okay, Dr. Accurso, you have the floor.
Thank you. I'm going to try to share my screen here. Let me know if that goes through. Thumbs up, folks can see. Okay. So my name is Anthony Accurso. I'm a general internist, primary care physician at NYU Brooklyn Family Health Center. I'm an addiction medicine specialist. Full disclosure, I know Dr. Ramawi a little bit from our time together at Park Ridge. Nice to see you. I'm going to talk today about a condition that I think many people have heard about in the news called opioid use disorder. And I wanted to start off, I want to encourage everybody, I'm going to give you a few seconds. If you have a piece of paper or something, scribble down any thoughts or questions you have about it before I get started. And then at the end of the talk, if you still have them, then serve them up. Quick show of hands, how many people have heard of opioid use disorder at present? I see you guys on my screen here. Okay, and then you can use, I see some people know how to use the hand function on the Zoom, so great. So I want to go ahead and get started, and by the end of the talk, I'm hoping that everybody understands what an opioid is, and I'm hoping to generate some empathy for the experience of what it is to be a person who's dependent on opioids. And I want to make sure everybody at the community board understands the treatment that's available for opioids and have some strategies for engaging people who use the opioids. I want to immediately start off by pointing out that the treatments we have for opioid use disorder are really potent. They're really effective. And so anybody who has opioid use disorder who's not on treatment is really potentially missing out. And just to sort of show that this is still in the news, this is September of 2020, but the New York Times did a segment on someone who was doing really well with opioid use disorder, and then in the setting of the pandemic felt very lonely and kind of relapsed on opioids and ended up dying. And it might not have happened if that person had been able to continue their treatment during COVID. But before we start, I want to just open the floor here. Now, I like participation, so feel free to unmute. I'll try to monitor the chat as well, so feel free to chat. I've got two screens here, so who knows what an opioid is? Or who can name one?
It's an addictive drug.
So it's a medication that is potentially addictive. That's true. There are others, but that is one component of opioids, is that some people, not all, not even most, but some people will become addicted to them. Other ideas on it? What we use them for?
Oxycodone.
Yeah, so oxycodone is probably the most famous current opioid, and the trade name for that would be either Percocet or Roxycodone. Perfect. Can anybody name another one?
How about Xanax?
Xanax is actually not an opioid. It's a benzodiazepine, a sleeping pill. But it's important to note because nowadays we're seeing more and more people misusing Xanax. And opioids themselves can be a little bit dangerous, but opioid plus Xanax is very dangerous. It's much easier to overdose in that setting. All right, so I'm going to go ahead and show some examples of opioids right here. And I structured the diagram kind of going from left to right in terms of weak to strong. So opioids are a class of pain medications that interact with a part of the brain called the opioid receptor. The original opioid was a plant called opium, and still is. That plant was refined into one of the first medications that we used for pain in the 1800s, which was morphine. And morphine is still around today. Let me see if I can annotate here. So you guys see this, me moving the mouse there? Yeah, okay, so there's morphine. And then, so morphine was refined over time into other opioids. And so now a weaker opioid from the opium plant is codeine. So if you ever got Tylenol 3 from a doctor, that's an opioid, but a weak one compared to morphine. And then you have hydrocodone, which is part of Vicodin or Norco. And then oxycodone, which can be packaged by itself or with Tylenol into Percocet. Dilaudid hydromorphone is frequently used. And a very similar compound to these medications is a medication that we could call diacetylmorphine, but goes by a more common name, which we call heroin. And so heroin is a pain medication that is Schedule I and is illegal in this country, but it's readily available in our neighborhoods and in our streets. And it has been for a long time. But finally, the most potent opioid that we now see is an opioid that was really developed for surgery. It's so strong that you're not supposed to use it unless an anesthesiologist is watching over you. But that opioid is called fentanyl, and that's the one that's on the far side of the diagram. Feel free to chat questions if there are any, but I'm going to keep moving. So just to try to show the difference in strength between heroin and fentanyl, these two vials contain an equal dose of pain relief. So pure heroin would be on the left and fentanyl is on the right. And what we know is in the last 5 years, increasingly, drug makers, illicit drug makers, are changing the street product so that instead of using heroin, they are selling people what they say is heroin, but they're really making it milk sugar plus fentanyl. And you can imagine if they put just a little too much fentanyl in the street product, that product becomes too potent and people can get hurt by that. So let's just talk. I don't want to completely vilify opioids. The truth is that they're complex. And so they have both some helpful qualities and some dangerous qualities. Can anybody throw in the chat here some helpful things that opioids do?
Kill pain.
Yeah, they are our single most potent painkillers, and they kill two kinds of pain. They kill physical pain. They also kill emotional pain. They're very good at that. Other helpful things? So I'll tell you, the opioids are very potent antitussives. They help people to not cough. And they're very good at constipating people. But so if people are having severe diarrhea, these are actually helpful. And they also make people not feel short of breath. So these medicines are very useful at the end of life. So if you've ever known someone who was on hospice or palliative care, morphine is the single most important medication that you can provide to somebody who's on hospice. Now, another effect that they have is that they almost always produce meiosis, which is pinpoint pupils. So keep that in mind. I don't know that that's helpful, but it's helpful for knowing if someone's on an opioid or not. And something that they do also cause is euphoria. They make people feel really good. And you can imagine that can be both helpful and not so helpful. But they have dangerous effects as well. Constipation, confusion, and the most serious effect potentially of an opioid is respiratory depression. People will stop breathing and not really care that they stop breathing. And that's what actually leads to deaths from opioids. And so let's do a clinical case. If you come onto this situation, you see somebody down and you look at the pupils and they look like this, they need help. And does anybody know what the treatment is in this situation?
Narcan.
Isn't it
Yeah,
Narcan?
Good. So
Naloxone.
anybody who said Narcan, which is the brand name for the drug naloxone, got this right. And so this is what naloxone looks like. It can be drawn up by EMTs and injected, but it can also be carried around by common, but just by us, by citizens, in a nasal form. And so it can be just injected into the nose, and it reverses the effects of the opioid. People will wake up very fast after Narcan. They may not thank you, because they're going to feel really bad. They're going to feel all of their pain relief disappear, but at least they will wake up. So I want to show you now some statistics from the city. First off, if we think about the city and you want to know one statistic to be able to sort of tell people, every day in the city, about once every 6 to 8 hours, somebody dies of an opioid-related overdose. So that's about 3 to 4 people per day in New York City who are going to overdose, statistically on average. And if you look over time, that has been going up. And we believe the reason why that has been going up is because of fentanyl. You can see that it's starting to level off a little bit, and we think that part of that is because of some successful drug policy, including increasingly offering people treatment. We don't, however, have the COVID numbers yet, and there is concern that this number is going to jump again because people might not have been able to access treatment during COVID. And you can see here that the substance that's really been the most dangerous for folks is the fentanyl. And the fentanyl is now showing up not just in heroin, but also in cocaine. And this is just urine toxicology without the name on it from my practice. I don't want to get too technical here, but if you doubt whether there's fentanyl in the drug product or not, sure enough, when somebody pees in a cup and we send off the toxicology, we see heroin, but we also see fentanyl. And this specimen is from 3 or 4 years ago. Now it's really the rule, not the exception, that there's fentanyl in the drug product. And you can see just a breakdown here by race and also by borough. And getting a little more granular, because I know this is CB10 we're talking about. I'll go ahead and you can locate your district in the catchment area here and see that the good news is that opioid related deaths are not the highest in the city in Bay Ridge and the surrounding area, but they're also not the lowest. I mean, we're really in the middle. Any questions so far before I delve in a little further? Josephine Beckman had put in correctly in the chat that opioids can be used after surgery. And they should be, but usually only for 3 to 5 days. There's a question from Judith Grimaldi. I'll take it. Or maybe not. I can't tell. She's got her hand raised.
I'm trying to unraise my hand, but it won't unraise. And
Okay.
You can raise your hand if you like.
I'm trying to take it away there. Okay, now it's gone. Sorry.
Your question has been unsubmitted. I'll go ahead and go on, but if anybody has questions, don't hesitate to interrupt. I don't mind that at all. So I want to now examine some of the reasons why people use different types of drugs. And there are really 2 main reasons why people use certain kinds of drugs. On the left-hand side, some people use drugs because they like how they feel on them. They feel better on them. But other kinds of drugs, it's not so much that people like how they feel how they're on them. It's that they hate how they feel if they're off them. And that might sound like the same thing, but it's actually not. So I'll invite you guys to think about, like, what is a drug where people just like how they feel how they're on it? It doesn't matter so much if they're not on it. Can anybody name a drug like that? Not from personal experience, but just if they want to guess.
I would think most illicit drugs, right, that you hear about.
Many illicit drugs, but specifically the one that comes to mind is cocaine
Cocaine.
and amphetamines. So something like crystal meth. People like how they feel when they're on it. They feel great when they're on it. If they don't have it, they feel bad the next day. They're like, I kind of miss the meth that I used yesterday. I miss the cocaine. But they can still get up and do their day. On the flip side, somebody who uses opioids every day for a month or so becomes dependent on them. And this is also true for benzodiazepines like Xanax. And so for somebody who's opioid dependent, it's really no longer that they want to use an opioid every day. It's that if they don't use an opioid, they feel the worst flu-like illness that you can imagine. So the symptoms of just pain everywhere, diarrhea, goosebumps, yawning, a feeling that all is doomed. It's a very unpleasant feeling. And so the key point is for opioids in particular, most people are not trying to use to get high after they've done it for a few months. It's that they're using just to get back to feeling normal. They're trying to achieve a normal state for themselves. So the act of having to go out and get heroin or go out and buy oxycodone, that act becomes all-consuming. You have to go make sure you get enough drug for the day, and then after that, you can go be a parent, or you can go be, work your job. You can go be a productive member of society. But if you don't get your opioid for that day, you can't. You're stuck in bed, or you're stuck near the toilet. So this is what I've found, now having worked with patients with opioid use disorder for about 7 years, there's sort of 2 or 3 stories that kind of all tend to intersect. One is pretty common, is that somebody got prescribed opioid pain medicine 5 or 10 years ago, maybe for a broken ankle, for a tooth, for some kind of injury. And after a certain period of time, the provider stops prescribing it to them. And so they have to start buying oxycodone on the street in order to not feel sick. Another possibility is that people start recreationally. They start using drugs a little bit and they kind of like doing it, but then it seems like a good idea to do it more and more often. And then they then develop the dependence that way. Now I see a hand from Jill. I'll take the question and then I'll move through the diagram.
Oh, no, I'm sorry. I wanted to say that it's almost similar to maybe alcoholics who you were asking that question before. So my hand was still raised. If there was any other.
Oh,
yeah. It's similar to an alcoholic as well. They're functional, but they need to continue to drink because they feel worse when they're not drinking, but they can function when they're drinking.
That's right, Jill. So I probably should have put alcohol in there. So alcohol starts off in the left column. Most people live in the I feel good if I drink column. That's where societally, that's where most people are. But when somebody starts drinking every day, if they don't drink the next day, they develop the shakes and they don't feel right. And they are alcohol dependent. They need a drink. And so it's exactly the same principle. They're drinking not so much because they want to, it's because they have to. Thank you for that. So there's a big hint on this slide, but I'm still going to challenge you for a minute. So let's say that we were opioid dependent. Okay, everybody, I just want you to take a moment to imagine that that was your situation. And you're going to go buy oxycodone on the street. And because you don't have a doctor to do it. So I don't know where you would go, but you would go somewhere. And how much do you think it would cost to buy 10 milligrams of oxycodone?
Dr. Corso, I'm no expert, but from my understanding, I think it's
$5.
it's $1 a gram.
Cheap.
It's $1 a milligram.
A milligram.
$1 a gram. If you see oxycodone for $1 a gram, you buy it because
I'm sorry,
boy, you could make a
milligram.
lot of money. But no, I strike that from the record. We're being recorded. But the idea here is that it would be $10 to buy 10 milligrams of oxycodone, and it would be $30 to buy 30 milligrams of oxycodone. Now, what's a typical oxycodone habit? How many milligrams a day?
10.
Maybe 20, 40.
More? 50?
So you need 30 milligrams about 3 times a day.
Wow.
Maybe 120 milligrams a day. Maybe you need it 4 times a day. So that's a pretty typical opioid dependence. So let's all imagine here, if you're not in treatment, then how much money do you have to spend a day just to live?
1,200.
Yeah, well, I get $120, but then if you do that for 10
Oh.
days, then you're at $1,200. I mean, this is going to cost more than rent. And so you can imagine that opioid use disorder has consequences, not just for people's health, but people's finances. And so people are smart, though, and resourceful. And so actually, many people realize that they can double the strength of their opioid if they skip their liver. Because when they swallow the opioid, they lose half of it. But if you want it to go directly to your brain and not get broken down by your liver, rather than swallow it, you can
Use
Eat it up.
take it by nose. That's right. And so many people realize that, and they can double the effective dose of their opioid by taking it by nose. Now, nonetheless, people build up a tolerance to opioids and need more and more opioid just to feel normal. And so many people will then switch to a cheaper product, because the equivalent of $120 worth of oxycodone can be bought for about $20 if you switch from oxycodone to heroin, because 2 bags of heroin will keep you out of withdrawal about as well. And a dime bag of heroin is $10. So many people who've been on oxycodone for a long time will switch to heroin for very rational reasons. And some, but actually not most, but some people will progress to then injecting heroin. But I find that that's actually the exception, not the rule. Most people are using by nose. Is that helpful for folks?
Yes.
Okay.
Sadly, yes.
Yeah.
So I do this because I want you to just sort of develop some empathy for what the experience of opioid use disorder is like. So let's talk about this. If you understand opioid use disorder, then really, what is it that we have to do in order to let this parent or this worker work? Like, what do they need?
Cheap heroin.
So there are some countries that actually do that, but ours is not one. Heroin is Schedule 1. But what they need is they need enough opioid that they can be kept out of withdrawal. And so we need to block that feeling that they're withdrawing from the opioid. And so there are 3 different ways that this can be done. One is with a famous medicine called methadone. Now, this is, generally speaking, only available in clinics, methadone maintenance clinics. And I'm going to show you a few that are in Brooklyn. I cannot prescribe methadone from the doctor's office from which I work because I'm not a methadone maintenance program. However, I can prescribe the next newest medicine for opioid use disorder, which is called Buprenorphine. But the trade name for that is Suboxone.
Mm-hmm.
How many of you have heard of buprenorphine or Suboxone? I'll check on the. Okay, so I'm seeing some hands. How many people have never heard of buprenorphine? Oh wow! So I got to teach this, or Suboxone. So, and then the other option, which I actually don't favor so much, but it is an option, is a full blocker, basically a 1-month Narcan called Vivitrol. It's a shot that lasts for a month. I see a hand up from Judith Grimaldi.
No, that was my answer. That was my answer.
So I'm going to teach you a little bit about each of these, and then we'll take it from there. So methadone maintenance has been around since the late 1960s, and it's actually the definitive therapy for opioid use disorder. Methadone is basically an all-day opioid. So you take the methadone and you feel as if you've gotten your dose of opioid for the day, and it lasts all day. The problem is, if you hand somebody 100 methadone tablets, if they take them too fast, then overnight the doses all stack up slowly, and it's very easy to overdose. And so therefore, in our country, we say, we won't give you that much methadone at a time. You have to go to the window where a nurse is working, get medicated for the day at whatever your dose was yesterday, and then you put the cup down, and then you leave and go to work. And methadone clinics open at about 6 or 7 in the morning. So people can go do this, and people at their work won't even know they're on methadone. And they do very, very well. But it takes a lot of time. But it takes less time than going and finding your heroin every morning. So many people choose to do this. And I just want to show you, I don't know if you guys know Brooklyn well, but when you're driving under the BQE, this is 20th Street and 3rd Avenue. Like if you drive 3rd Avenue, and this is South Brooklyn Medical Associates. This is a methadone clinic. It's my favorite. And they treat several hundred people in our local community, most of whom you probably don't know are on treatment. Vincent P. Dole, this is in the Pathmark building near the Lowe's over in Park Slope, another large methadone maintenance facility. Here's one in Manhattan. And so this is an option for people. I don't know if that was helpful. Hope it was. Questions on methadone before I go on to Suboxone?
Oh, you have a question,
I'll take it.
Joe?
Yes, on the methadone, people are on that all their life.
Yeah, they may be. So people will go on methadone for months to years. And if you think about it, they're just plugging their brain's need to feel an opioid. They're basically, it's best thought of as being like insulin for somebody with diabetes.
Yes.
Except instead of diabetes, it's somebody whose brain needs an opioid every day. And methadone is the insulin. Except it's not
Because
insulin.
I'm sure there's people that have been going for 30 years to the same place on 20th Street and 3rd Avenue.
That's correct.
And you see the same people, and they're not really functioning like you would say normal people going to work. I'm sorry.
Well, so I think I'll meet you halfway on that. So some people continue to have a drug-involved life, but for every person like that, there's somebody else on the program who's just going to work, and we just don't know.
Okay, we have
So
another
would you
question.
say it was a 50-50?
I don't think I can comment because I don't work there, but I think 50-50 is a very reasonable estimate.
Right.
We have some more questions. Jill Hajar,
I'll go for Jill.
Jill, you have to unmute. You're still muted.
With all due respect to the methadone program, which I highly agree with, because you have to deal with the people who are struggling at that moment.
Mhm.
I have 2 cousins that are now deceased from the 1960s, like you spoke about, that were on that program and never came out of it.
Thank you.
What I am most concerned about is the mental health issue that has to do with why people go to drugs to begin with. And I think more money should be put into the mental health situation and why kids and teenagers and people go to drugs to begin with. So as much as I agree with this methadone program for the immediate shot in the arm, as you might want to say, I think it's just not a very good program for the long haul. So that's my opinion.
Yeah, I think a lot of people have different experiences with methadone. And I think Jill brings up a good point. So people use drugs for a lot of reasons, but often it's to help them cope with some other kind of psychological trauma that they've suffered. And the drugs don't necessarily fix that. But then, if you have psychological trauma and you're in opioid withdrawal, that tends to go worse, actually. So I think an important part of treatment, and I don't want to dwell too much on methadone because I'm talking about treatment that I don't do, but an important part of treatment, I'll get to Dr. Ramani in a second, is trying to connect people with mental health services, which should be available. Dr. Ramani? I think you got you on mute, my friend. I didn't copy that.
Dr. Mel, you're still on mute. You have to unmute. Can you Okay, there you go.
You hear me?
I got you now.
we hear
I got you
Yeah.
now.
Is methadone considered as an opioid itself?
It is a synthetic opioid. That's correct. It
Because
doesn't
some
come from
people
opium.
Some people are against it because they say it is an opioid, which might end up with the same problem itself.
Yeah, I think I'm going to table this for a second. after I present, let's re-ask that question and see how we think about it. I think what I'm going to challenge the audience with is addiction the same thing as dependence? So I want you to think about that, and we'll come back to that at the end of the talk, okay?
Okay.
I appreciate all the input from the audience. This is excellent. So I want to now teach you about buprenorphine. So buprenorphine is the active ingredient in Suboxone. And Dr. Malley, we might see if you can mute. So we've got, thank you. This is different from methadone because instead of being a full strength opioid, it's a half strength opioid. I often tell people, imagine the opioids sort of like the dial on your stereo. So people who don't use opioids living, our dial in our brain is set at about a 3. And heroin turns it to 10. Oxycodone turns it to 10. Morphine turns it to 10. And methadone turns it to 10. What buprenorphine does is it sets that dial to 5. It's a half-strength opioid that lasts all day. And so what most people who are opioid dependent report is, when I take Suboxone, I feel normal. I don't feel high, but I don't feel sick. And it's a medicine that's taken under the tongue, which is why we have that picture right there. As people swallow it, they lose it. And some people really don't like the taste of it very much. And another important aspect of buprenorphine Suboxone is currently, and this may change in the next year or two, but currently not all doctors can prescribe it. In order to prescribe it, the doctor has to do an 8-hour course, which is not too much to ask, but many docs don't do it. So you have to know that a doctor you're going to has done the 8-hour course and has what's called their X waiver in order to prescribe buprenorphine. So I just want to show you the waivered providers who are in the neighborhood. So I work in 2 clinics at Station 12 and at Sunset Terrace. And I have colleagues at each of these clinics who they all do buprenorphine therapy for patients. And April Kramer-Scagno is our Suboxone nurse, our buprenorphine nurse. And she staffs a phone Monday through Friday called our warm line. Perhaps you see it there. And in fact, now's a good moment if you have a piece of paper or something like that. You might want to write this number down because patients or family members or doctors can call this number if they were trying to get people into treatment. And April will help with the initial steps and will make sure that that person sees a doctor who's capable of writing for buprenorphine.
Dr. Corso, let me just interrupt 1 second. So I will forward that number and any contact information to Josephine, so she will also be another resource. And then just to clarify, Station 12 is actually at our main hospital on 55th and 2nd Avenue. Not a lot of people know where Station 12 is at.
Thanks for that, Sarah. Yeah, I said Station 12, but it's, Lutheran Hospital. Except I can't call it that anymore. NYU Brooklyn. Okay. And this is our flyer. Yep.
If I can also add, I'm the director of the Jewish Board Bay Ridge Counseling Center.
Oh, excellent.
And so we do, so Jill was talking about, the mental health component. So we very much work with people who have what we call co-occurring disorders, have substance use disorders and mental health needs. And our psychiatrist was recently took the course for the
for buprenorphine.
Yes, so he's just done that.
Wonderful.
So we're kind of learning more because our focus now is we don't want people to feel like if they walk, like whatever door they walk through, if they come through us rather than a program that is more geared to substance use disorders, we want to be able to treat them. And so we're really growing in that area. It has not been an area of real expertise, but it is an area where we're rapidly growing. So, and it's great to have colleagues as yourself and these programs through NYU Brooklyn available to the community.
No, I'm really happy to hear that. And treatment of co-occurring disorders, so treating a psychiatric disorder at the same time as a substance use disorder. I mean, it's like peanut butter and jelly, like they're better together. And increasingly, like the more that people can uptake the buprenorphine waiver, the better. So we can be in touch offline about that. I think I see a question from Sandy Vallis.
Yes. I want to ask. I know with the opioids, there's a criminal component attached to this where people who are hooked on it and need to get their dosage will steal from their families or steal whatever they can to take care of their addiction. The other programs that you mentioned, is there a charge for this, or does insurance cover it?
Yeah, I'm glad you asked that. So that's a two-part question. So let me tackle the second part first. So the nice thing about buprenorphine therapy is, so we no longer think about opioid use disorder as a moral problem. Like, we're not like this is a bad person. We say this is a person who has a health condition, and the health condition is called opioid use disorder or opioid dependence, and insurance companies have to cover it. So if somebody has insurance, they can see us for treatment of their opioid use disorder, and we can prescribe the buprenorphine, and it really has to be covered. I mean, they may have copays, but you know, that it shouldn't be outside of insurance. So the first part, what we call, what you're describing is something that's called acquisitive crime. And if you were paying attention to sort of the beginning of the talk, it kind of makes sense. Like, somebody needs to function. This is the exception. Like, you would think, like, I don't know, people steal stuff out of my clinic and stuff. I've never seen that happen in 7 years. People don't do that. I mean, like, some people will do that, but I don't find any higher risk of that happening in my opioid use disorder clinic. You know, folks who are using opioids are reasonable people. They have a dependence, and it's something that we can really absolutely treat.
Well, it's that dependency that makes them need to steal, because if they don't have money to get their dosage, they're going to become desperate.
Yeah, I mean, that's the, I mean, I think the idea here is that opioid use disorder is a powerful brain issue, and some people say it's sort of a disease of the choice organ in our brain. But I also want to point out that it's a disease that exists on a wide spectrum, and before it gets to the point that you're describing, Sandy, you know, that's maybe the 1 in 100, and there's like 99 people who haven't gotten there yet and haven't compromised their principles yet, and we just don't see them because they're spending money that they earned on the opioid, or it hasn't gotten away from them yet.
Yeah. So if they don't have insurance, they would need to cover the expense on their own, won't they?
Potentially, yeah. I will say that, so for people who don't have insurance, buprenorphine can be a real challenge, and methadone might actually turn out to be an easier option. We can cover people for a month or two at a time if they don't have insurance. We have a grant for that, but I can't, like, carry somebody for a year. But it is interesting.
It's a problem anyway you cut. It's a problem.
Agreed, and one that really has very optimistic outcomes. I want to also point out, it's sort of interesting, but I haven't seen much opioid use disorder among people like self-pay patients or patients who don't have insurance. You know, usually folks who are immigrants or such. I think this is largely a disease of the American healthcare system. Actually, you know, the last 20 years have seen a very heavy reliance on opioid pain medications, which we now know is at least partially due to the aggressive marketing that some of the makers of the Oxycodone did. And so now we have a generation of patients who were exposed to opioids, and now we have to work on it together.
Maybe there should be a fund collected from each of the pharmaceuticals that make this these opioids, to help in trying to get people off of them, but it's a money issue.
I agree with you, Sandy, and I don't want to veer too far off topic.
Yeah,
but,
I understand. Okay, thank you.
But Purdue Pharmaceuticals has been, they've been assessed, you know, $1 billion in rations or something like that. But then there's a lot of question. Okay, so where should that money go? Should it go to treatment, or should it just go to the state, because the state has already paid for a lot of Medicaid to cover people's emergency room visits? And, you know, there's a lot of interesting talk about how best to use that money.
Yeah. Okay.
I want to show you Vivitrol. Vivitrol is an important medicine, partially for opioids, although I think it's less good for that. But this actually turns out to be very effective for alcohol use disorder. So people who are drinking heavily, if they are interested in either taking naltrexone tablets or taking a Vivitrol shot, they can sometimes find that they drink much less. And the reason is because this medication blocks the fun of the third drink. So, alcohol used in low doses kind of behaves like Xanax, but when it's used in higher doses, it behaves a little bit more like heroin. And so blocking those effects help people to drink less. And that's also treatment we can provide here. So one question is, well, why not just send everybody to detox? Why don't we just send people in for 5 days, or if you've seen the movie Ray or the movie about Johnny Cash, you've seen them go through opioid withdrawal and they kind of walk away at the end and they're fixed. But it turns out that doesn't really work very well, because people finish the detoxification and then they return to the environment where they used to use. And the urge to use is very, very high. And so what we see is that, 30 days out from detoxification in this study, fully 80% of people had gone back to using. So if you put people on buprenorphine maintenance, you see, you extend the time out from a month to a year here. You can see that people were retained in treatment much longer if they take Suboxone. Or, this also holds if they're on methadone, but that's not what this study was studying. So these medications really do help people. This is what buprenorphine looks like. People will either take it once, twice, or 3 times a day. And this is what treatment with me looks like. People will come in. People who are stable usually come in about once a month, and we'll do a urine test, and we'll try to see if they're taking the Suboxone and if they're taking other drugs or not. And if they're taking the Suboxone and not other drugs, some people even come once every 2 months or every 3 months. But if they're not taking the Suboxone, then we just try to see them more frequently. And we try to make a determination about whether they're doing okay in treatment. And if, after a little while, if they can't stabilize, then we'll refer them to a methadone maintenance program. I think it's good to think of buprenorphine as the easier, less intense therapy, and then methadone as the more intense therapy. And we do the urine drug testing just to see, and this is like a stable patient. This is a less stable patient. So you see here, a stable patient's not using other drugs. They're taking the Suboxone and they're doing great. And this patient over here using substantially more drugs and is not really taking much of the buprenorphine. And this is somebody we would probably refer to a higher level of care. I'm not sure if Nurse April Kramer-Scagno is on the call. I'll just see, I'll give her a second if she's calling in. So she was going to potentially talk about words. So before we...
No, I'm here.
Oh, is April on?
Yes, can you hear me?
Yeah, we got you, April. Do you want to talk a little bit about words? And maybe actually introduce yourself, talk a little bit about what you do. Let me put your face up so people can see you. Here you are.
The other thing I just want to touch on that Sandy mentioned, with the program, first off, a lot of these patients are being seen in primary care. So, so no one knows what they're coming in for, which is a good thing. And usually if they don't have insurance, we do have a grant that we can subsidize for them for 1 or 2 months. But in the interim of all that, we do get them connected to insurance. So whether it's Medicaid or Medicare, but we do make the connection for insurance for them, which pretty frequent. Everybody gets insurance. So as I said, we can carry them for so long until the insurance kicks in. So that's one thing. Speaking about stigma, there's a lot of stigma related to opiate use. And it's a sad thing because people actually, with the stigma, they don't come in for treatment. And the good thing is that because now treatment is being done in primary care, no one really knows what you're coming into the primary care area for. You don't know if they're there for high blood pressure, diabetes. So no one knows. You're just in there and being able to get the treatment for opiate use disorder and within the primary care treatment, which has been really good. But there's still, no one wakes up in the morning and says, oh, I want to start using drugs today, or I'm going to be, become, and I hate to use the word addict, but no one wakes up to say, I'm going to be a diabetic today. It happens, and many, many times, and they cannot prevent it. And it's not that they want to be like that, it's just because it happens. And they sometimes just don't have control. But because of with the stigma, there's a lot of terms that we try not to use anymore, such as dirty urine. Now we like to say that it's negative, or if it's a positive urine. We don't like to use the word addict or abuser or junkie, where years ago that's what you used to hear. So we like to just say that a person with a disease of addiction, or people with who uses drugs or injects drugs, and or instead of saying clean or sober, you say addiction free or in remission. Recovery, we like to use the word addiction survivor. And abuse or substance abuse, you do want to use misuse, substance use disorder. And also for treatment, the medication assisted therapy. And to compliance, you want to say that they're keeping and adherent to the program. Mm-hmm. So, but the patients themselves actually will feel that stigma also. And a lot of times they don't feel good about themselves, which is sad, because it's a sad situation, and many, as I said, they struggle with it. And when you try to give encouragement, they feel good about giving them encouragement, or if they're doing well. And the majority of times we do try to connect them with mental health. We have behavioral health at Sunset Terrace. That many patients, we have referred them to mental health. So, and that works great. If you could get them into therapy, it does work hand in hand, and and we have really good outcomes.
I see Jill's got her hand up.
Yeah. So I'm just curious, because this is the second time in 2 years that I've been to an information session on opioid addiction information, which I think is fabulous and great. And I agree with everything that both of you are presenting. However, I'm just curious, because it's the second time in the information session that you are introducing this new drug in placement of methadone. Yeah. So is this information session to introduce this new program for this new drug, or is it to talk about opioid addiction and how we can further help the people that are addicted to opioids? And like I said, really get to the crust of the problem, which is mental health issues, and maybe incorporate mental health along with these programs. I just feel that the second time that I'm listening to this keeps bringing up the new drug in placement of methadone. And I think it's great that we're trying to help the people that are already addicted, but I feel that NYU in particular should really focus on more than just the drug and incorporate the mental health component as well. So I'm just curious if we're trying to promote this drug over methadone or not.
Well, Jill, that's interesting. I write for a lot of buprenorphine, not always Suboxone. It's generic now. So, I don't have any specific allegiance to any one medication over the other. It's just that's the medication that I can prescribe from my clinic. So I don't think anything that you're saying is incorrect. Mental health treatment really helps. But I want to point out a couple things. This has been studied. You know, they actually did a study where they put patients into 3 groups. One group got opioid. I'm sorry, one group got buprenorphine. Another group got buprenorphine and talk therapy. And another group just got the therapy, like the talk therapy without the medication. And they looked at the treatment effect, and the 2 groups that got the buprenorphine had equal outcomes. They did better. And the therapy alone without the buprenorphine didn't do as well. That's not to say that therapy doesn't help. It does help, and it helps some people. But the point of view of the city health department, and frankly, my point of view professionally, is that for this disease in particular, opioid use disorder, we have awesome medicines. And just to put some numbers on it, so if you treat if you treat like 100 people for 2 years, you're going to save 2 lives. And that's with buprenorphine. You'd save more with methadone, but that's because by the time people get to methadone, their chance of dying is very high. I'm going to see if I have that in a figure somewhere, which I could try to pull, but I'd have to kind of scrounge it up. And I don't want to necessarily take the board's time doing that. Although if there's question and answer, I might be able to.
No. I understand what you're saying, and I agree with you treating the problem at hand. I'm just asking because it's the second time that I hear that you're comparing methadone programs with this particular drug. So is that what this information session is about, is to explain the difference between the methadone program and this particular program? Regardless of whatever program there is to treat this addiction, which I agree with 100%, I still feel that the bottom line is that we really need to put more money into getting to the problem before our children and teenagers and adults get addicted. So I believe that there has to be a component of drugs, yes, once they're addicted, and therapy, or therapy first along with drugs when they're younger. That's my only issue. And once again, I'm just trying to figure out this information session. Is it more about comparing the methadone program to this particular drug? Because like I said, you mentioned it several times, and I heard this a couple of years ago when I went to a same situation session from NYU about this particular drug. So I'm just curious why you keep bringing up this drug versus methadone.
Yeah. So I think that Jill, you made your point pretty clearly. But I just want to sort of bring up a few points that we brought up earlier in the talk. So I challenged the audience to say, is addiction the same as dependence? And do folks think that it is the same, or are they different?
I think dependence starts first. People need to be dependent on something to make them feel better. And then addiction comes after. And then addiction then breeds dependence again. So it's a vicious cycle.
Yeah, I'll offer, if anybody else has any other thoughts, maybe I'll try to give a few hints here.
Say it.
So for instance, so the technical definition, if people are dependent, we're dependent on something if when we don't get it, we feel withdrawal. I will readily note that I am dependent on coffee. If I don't have my coffee in the morning, I feel withdrawal. And I don't think I'm the only one on this call who's probably dependent on coffee or caffeine. So how's that different from addiction? Oh, okay, there's caffeine on the call. Thanks, Sarah. So I think addiction tends to involve things like craving, role failure, not being able to complete your daily tasks. So you ask yourself, okay, is somebody failing at their responsibilities because of the use of the drug? So if you're late to your morning meeting because you had to go to Starbucks and wait online and buy a coffee, and then you lose your job, we might say at that point, you're no longer dependent on coffee. You're addicted to coffee because it caused problems for you. But if we apply that now to other drugs, like people become dependent on their heart medications. Like there's a medicine called metoprolol that slows down people's hearts. If they stop it, their heart races the next day. Are they addicted to it? No. But are they dependent on it? Absolutely. So both buprenorphine and methadone tend to cause opioid dependence. People they have to stay on those medications in order to feel normal. But what they don't do is they don't cause role failure. People don't crave methadone and they don't crave Suboxone. People take those medications as treatment for the condition opioid use disorder. And I challenge the group, as we all, if you have people in your Community Board 10 constituency who come to you and ask, what can we do about opioids? I think an important first step is to try to think of it less as something that somebody's choosing to do and more as something that is a medical situation. So just like high blood pressure means that people have to take a pill every day, and just like diabetes means some people have to take a pill every day, or some people with more serious disease have to give an insulin injection every day. People with opioid use disorder, they have medication that they have to take every day in order to function better and in order to be protected from overdose. And if we all allow ourselves to try to view this condition in that way, it starts to make a lot of sense. And I think it gets easier to avoid some of the stigma. So I'm a little wary of the time. I'm perfectly happy to stay on, but I'm not entirely sure how long we have to go. Do folks, do we have a word on how long we have for the agenda?
Iris is, yeah.
Sorry, I was getting myself off mute. We can stay with you, but we do want to progress in the presentation. I also kind of want to come back to Jill because there are more medications now. They are very helpful in treating people, particularly people with addiction, and there is a real distinction. But I also want to let you know that the Office of Mental Health and the Office of Addiction Services are merging. And I think that that's a real indication of what we're saying tonight, is seeing substance use disorders within the mental health
Context.
Thank you, doctor. Yes. So we all working together on this issue, and it's all important. The talk therapy, the medical oversight, the medications, with it all coming together, we're finding it much more helpful and in serving people. So I just wanted to say that.
I agree with you, Iris. And it used to be that addiction psychiatry was its own thing, and psychiatry was its own thing. And psychiatrists who, the second they heard, oh, somebody's using Xanax, or somebody's misusing heroin or something like that, then they would say, okay, I can't treat this patient. They have to go see a specific addiction psychiatrist. And then once they're off all the substances, then I can treat them. And I don't know about you, but that doesn't sit right with me. And I think, just as Iris is implying, the field, both medicine and psychiatry, are moving in the direction now that substance use disorder is just another part of a continuum of mental health disorders, and integrated treatment can really help people.
And this also lessens the stigma. So as the nurse was saying before about where people access services, that may be very important for them accessing. If they're going to a setting where they feel it stigmatizes them, they may avoid getting treatment just for that very.
That's right. And there's so much shame, and like people just don't want to, be above board on this, and then they get hurt because they use street product that may be contaminated. They may buy something that says it's oxycodone, but then when you test it in the lab, it's fentanyl, and it's been pressed into a pill that looks like oxycodone.
We're also joined by our chair, Lori Willis, who has her hand raised. Lori?
Lori?
Hi, thank you. I have a question. It's a little bit off topic, but I am curious because we are talking about a question of, stigma associated with addiction and controlled substances. And also because, you treat people, so you really are the feet on the ground. I'm curious, in terms of marijuana use, with the legalization of marijuana maybe on the forefront, there is a destigmatization of that use. And I'm curious, is there any link between, marijuana use and possibly opioid use disorder? And what are you seeing, or have you seen any, dots being connected or not? Just because in my personal experience throughout my life, any people I've ever known who have ended up, getting serious, drug use issues never started, with that drug that they ended up with. It always started with something simple like marijuana. And that's just been my experience. So I'm wondering if you see anything, indicating that, or if there's any, you see any connection.
Cannabinoids are interesting. So in terms of potential danger, a cannabinoid, a marijuana, or a similar, generally speaking, far less dangerous in terms of causing people to stop breathing than an opioid. And I think we're seeing movement away from we're seeing movement towards the decriminalization of cannabinoids. And I think this is progress for many reasons. That the cannabinoids are differentially enforced. So even though people of different races, for instance, use cannabinoids in the same rates, they're incarcerated for it at different rates. So that's been a challenge. So decriminalization can help that. But in terms of like medical uses, the biggest challenge is that the federal law in regard to marijuana or cannabinoid is pretty antiquated now. I mean, it dates back to the 1970s, and it labels cannabinoids as Schedule I drugs. So we cannot prescribe them. We can authorize people to say that they have a medical condition for that might be improved by a cannabinoid, and then that once a patient gets that kind of card, and I should disclaim I can't do this, not within the family health center, but other doctors can do this. Once the person gets that card, they can report to a dispensary and pay cash to buy cannabinoid from a dispensary in New York. So it's very hard to study. It does seem that cannabinoid use tends to lower opioid use. So people probably who have chronic pain may get some pain relief from cannabinoids and then use fewer opioids. There was sort of a common story, which I think may actually be an unproven situation or a misconception, which is that cannabinoid is like a gateway to other heavier drugs. That hasn't really been borne out in the data. There's real problems with correlation and causation. People who are tempted to experiment with cannabinoid, in high school or whatever, they probably have different experiences growing up than the people who didn't feel the urge to do that. And so whether it's the cannabinoid that's causing them to then move on to other drugs, or whether it was the upbringing or the environment that they were raised in, I think is a complex question, and I don't think we know that yet. I could tell you frankly about how I treat cannabinoids in my practice. It really doesn't influence my decision-making very much, whether somebody's testing positive for THC, which is the active ingredient in marijuana, or not. Like I don't think that they're at any greater harm as a result of that. I will sometimes ask people, like, is it causing you trouble? Are you spending money you don't have on it? Are you driving while you're under the influence of the cannabinoid? Yeah, most people are like, no, I'm pretty responsible about it. It helps me calm down, or helps me with my pain. And at present, I'm content to kind of leave it at that. And I think if the laws change, I'll be eagerly awaiting to see what the data actually shows about the potential benefits of the cannabinoid.
Well, I guess, my question really wasn't to the law enforcement aspect of it. at all. I guess I was
Sorry,
really,
Maria,
I was speaking more to just, the social stigma aspect of it, but also the science of it. So as a doctor, I mean, and I just don't know, this is sheer curiosity. Like, do the compounds, whatever it is, THC or whatever's in cannabis, does it have any similarity to the compounds that you find in an opioid? Do you know what I mean? That one may fill the gap of the other, or no?
The medium or the long answer. The short answer is no. They don't. The longer answer.
Right, that's great. No.
The cannabinoid. I see your hand up, Dean. So the cannabinoid hits receptors inside the brain called endocannabinoid receptors, and we don't actually know all the purposes of these. We know that we have like chemicals in our body that send signals in our brain that are similar to marijuana, similar to cannabinoids. They're involved like with childbirth, they're involved with things like that. We don't know, like with immune reconstitution. Of note, like THC is the part of the cannabinoid that makes people kind of feel high and dizzy and things like that. CBD, cannabidiol, is actually responsible for some of the opposite effects. So it like can sort of boost the immune system, and it seems to be sort of anxiolytic. So like helps with their anxiety. So we may see, differential, as cannabinoids get more available. We may see products that have either like more THC or more cannabidiol, CBD, but it's a little beyond the scope of the talk. So I feel kind of obliged to call on Dean here.
Yeah, I just wanted to express my opinion on the marijuana issue, because there are many medical professionals who feel it's not bad if it's legalized, but there is a smaller group, I think, that feel, I'm going to use the word gateway, that's my word, that it is a gateway to other drugs. But my biggest, and for medical decriminalization, I agree with 1,000%. Medical use, I agree with 1,000%. But I have a problem with the recreational use. And maybe it's a distinction you can't make, but all we hear from the government, quote unquote, is the money that's going to be generated through legalization. I don't hear them saying it's good for you. I don't hear them saying it's going to help you. It's going to generate a lot of money. Now, again, I am not for legalization for recreational use. I don't know if you can, move forward without just doing that. But I'm concerned because all government sees are the dollars from the taxes. And as far as they're concerned, it's great because we're going to have tax revenue. So that's my comment.
I'm enjoying this talk quite a bit, actually, because I think the points are really interesting. And, clearly legalization would lead to tax revenue, which could be used for treatment. I think let's all take this discussion up to 50,000 feet in the air, and let's think for a minute. So let's think about the fact that alcohol can be purchased by people over 18. And as long as they don't drive while they're under the influence of it, can be consumed. And we trust adults to be responsible with it. And it is certainly arguably at least as potentially toxic as cannabinoid. And then if we think about, we say that heroin, diacetylmorphine, is illegal, but that medication was made by Bayer Pharmaceuticals in 1900. And we say that particular medication is not legal, but we say that a very similar medication, Dilaudid, morphine, or even oxycodone, these are all very similar medications. These are legal. And I sort of question to the whole group, like, well, why? What's the difference? Why can't, Purdue Pharmaceuticals just make heroin? But there's history tied up in it. And I think there's some, questionable drug policy. But it's not really my place to say that. It's my place to try to work with people wherever they're at, to try to lead, safer and easier lives. Lori?
Hi, sorry, I did not mean to move this into a different area with my last question, so I'm
Too
gonna
late.
try to bring it, I'm gonna try to bring it back with this one.
Okay.
So, I do, see through the presentation that, some of these drugs really do assist people just, for, their day-to-day lives and
Yeah.
possibly keep them out of harm's way, in terms of being able to function and staying alive, hopefully without overdose.
Yeah.
But what are the long-term, what is your hope eventually that they would be able to move off of these? And is there like, do you have a protocol to do that? Or is, it possibly just, opioid use disorder, a lifetime disorder that can only be managed?
Which of those do you think it is, Lori?
Probably, I don't know. I think it depends on the person. I think it depends on what brought you there. I think some people are able to, they'll always, struggle with addiction, and some people just, depending on how their life goes, sometimes it works out better for them. I think it's a tough thing that my personal opinion is, it's a very hard thing to live with. Obviously, these people struggle very much, and if life throws them a curveball, sometimes, it doesn't turn out as well for them, because maybe they don't have the support to get through it.
Yeah, April, do you want to chime in on it before I take a stab, or?
Well, I'll try. We do have patients then when they're ready, they actually start bringing themselves down.
Yeah.
But they really have to be ready, and they kind of do it on their own, where they'll slowly take less and less by the days or by the weeks. And eventually we hope to maybe get them off, but you still have a disorder here that's always there. So, whether they relapse, you just hope they don't, and try to support them as well as you can. But some of them, as we have one patient that's soon to be off it. And and he is getting counseling, so that's a good thing too. He's been going to centers, or to a counseling center where he's in group therapy now. So, so we have to wait and see. And the other thing is, buprenorphine is not just buprenorphine, it's also Suboxone is buprenorphine and Narcan. So there isn't the danger of them overdosing. They could never overdose on Suboxone. And that's like a really good part of this, this medication. Whereas if you methadone, you still can overdose on it. If you take too high of a dose, or you're taking multiple doses. But with Suboxone, you can, and you cannot. But and that's the beauty of this medication. And I wish we did, but we don't get kickbacks, and we don't get any promotions from Suboxone. We definitely don't, but it's just a treatment that can be used in primary care. And that's what makes it so good in treating opiate use disorder, because it can be treated in a primary care center. Whereas if you go to a methadone center, that still is stuck with stigma, because if they're going there, what that person's there for. Whereas if you're coming into a primary care center and being treated, no one knows why you're there. And that's the beauty of being able to have waiver doctors to prescribe Suboxone. And that's one of the reasons why we promote it, because people are more willing to come in for primary care. And many of these patients never had primary care treatment or physicals until they came in and being treated as a whole now. Whereas when they just go to a methadone clinic, they're not being seen as a whole person. So they're not getting their blood pressure taken. They're not getting, you know, tested for hepatitis or HIV or any of this. Whereas in primary care, they are able to get treated. And many of these patients haven't been seen for years.
Yeah, I agree with April, and forgive me. So what I did is I pulled up the talk that I gave to the to the pain management residents. So and I found the diagram I was looking for. Thank goodness. But before I do the diagram, I mean, I see there are 3 hands up, and I think what I want to, although Lori, I can't tell if your hand is still up or not. But the point I want to try to make is we tell patients, we want you on the lowest dose of buprenorphine on which you thrive. So if you can get to 0, we win. But if you stay on a quarter of a tablet once a day for a year or 2 years, we win. And frankly, if you're on a full dose of 2 or 3 Suboxones per day, and you're able to be a parent, and you're able to go to work, and you're able to earn money, and you're able to pay tax, and you're able to be a productive member of society, we win. Because we're not out to push people off of Suboxone once they're on, or buprenorphine once they're on. And I think an important concept here is that when buprenorphine came out, they put people on it for a month and then said, okay, that was long enough. Now go off and don't use heroin. And 8 out of 10 people go back to heroin. And so then they said, okay, well, we didn't do it for long enough. Let's keep people on buprenorphine for 6 months. And so people did great on buprenorphine for 6 months. And then we stopped it because we're like, that's long enough. Now just stop the Suboxone and don't use heroin. But then 8 out of 10 people go back and use the buprenorphine. So, I'm sorry, go back and use heroin if we stop the buprenorphine. So now we say, well, really, it may be that people who have had a period in their life where they were opioid dependent may be happier and better and safer if they just remain on buprenorphine. But I do challenge people to come off. I challenge people to say, if you want to come off, you lead and we'll follow. And we've had some people who've successfully done that. I see Dean and Jill. And I see who's on to. I guess I should probably go in that order. Just
hello, Doc. I'm on the phone. This is Joe.
Joe, go ahead.
Yes. Question: do you feel a lot of this dependency is inherited? That is going from generation to generation.
Well, that is a good question. Joe, what do you think?
I think yes.
Yeah, I agree with you. So here's what I know. Some people who I speak to, they take oxycodone for the first time, they vomit. They're like, this is stupid. I don't like it. And other people report they take an opioid and they're like, this really makes me feel good. And I think there are genetic differences in how people experience opioids. I also think that people's life experiences definitely influence their vulnerability to opioids, because opioids absolutely will help you deal with your trauma. If you had a trauma earlier in your life, while you're on the opioid, it won't bother you as much. When you're off the opioid, it'll bother you as much or more. But it's a logical thing for people to want to try to treat their trauma this way. What I often say, I try to ask everybody. I mean, I see 2 hands up, but let me go ahead and say, why do we have this darn opioid receptor? Or like, what's its purpose? Why is it in our brains making us vulnerable to the opium poppy? Well, so we have natural opioids in our body called endorphins. And we usually think of this as when you're running or exercising. This is what allows us to keep running around the park, even if our foot hurts a little bit. And more teleologically, this allows us to run away from a lion if it's chasing us without worrying about the fact that our knee hurts. We can worry about the fact that our knee hurts after we climb a tree to get away from the lion, assuming the lion can't climb the tree. But that's why we have this endorphin. But I challenge you with one more thing, which is anybody who's ever spent time with a 2-year-old child can recognize this. If a 2-year-old child falls down and skins their knee, there is a treatment for that that is very effective that can be applied by another individual, usually the parent. Anybody know what that is?
Band-Aid.
Band-Aid's okay, but there's a better treatment, assuming
A
they're not
kiss.
making a mess.
A kiss.
Yeah,
Kiss
a
They
big
kiss it
hug,
and make
a
it
big
better.
hug and maybe a kiss. But you
That's right.
you lift the 2-year-old up and you say it's going to be okay. And why does that work? That works because you're engaging the child's natural heroin, their natural endorphin system. That you're applying morphine to the child by giving them a hug. These drugs, the drug class, interacts with the part of the brain that says, I'm safe, I'm where I belong, and I'm out of pain, and I can calm down now. And so it's very rational that people who've experienced trauma or who live in a situation where they don't feel that way, maybe who are in a trench in Vietnam, can simulate the feeling of being okay by applying an opioid to themselves. So I don't know if that answers your question, Joe, but I do think that it stands to reason for both nature, the way we're wired. Some people are wired to really like opioids, and also nurture, the way we were brought up and the traumas that we face, make us differentially susceptible to opioid addiction. I see Dean, I see Jill, I see who's
Hi, Dean, I'm sorry, Dean, do you want to go ahead?
Yeah, I lost my screen, but I could still hear everybody. I just wanted to comment on the term opioid use disorder, which I think is wonderful, because just that title, I think, lessens the stigma, as was said before, which hopefully will encourage people to go for treatment. So that title, opioid use disorder, I think is excellent to, phrase it in that way.
I agree with you, Dean. And I do something else in my spare time when I'm charting on the patients. That the medical record's really just not an easy thing to work with. But I get patients and I see problems on the list: opioid abuse, like polysubstance abuse, heroin use, something like that. And I try, when somebody settles into buprenorphine treatment, I do my best to change the medical record to say opioid use disorder or opioid dependence, continuous, because I think that's less stigmatizing. And I do the same thing for, anytime I see like the word alcoholic in the medical record, I try to change alcohol use disorder. Because stigma is kind of insidious, and people will treat people differently based on how the words are written.
Absolutely.
I see. So Dean, thank you for your excellent point. Jill?
Yeah. Thank you, doctor. So
let me brace myself. Hang on. Okay, I'm ready.
So, two points. I just was a little alarmed about the fact when you were saying about the medication, when you take them off, they need to go back, and then you extended it and they needed to go back and needed to go back. I'm just a little concerned about the fact that they're just becoming addicted to another drug, which I totally understand. We need to.
Time out, Jill.
Wait.
Addicted or dependent?
Dependent. Okay, fine. But
fine, go on.
I have a daughter who is dependent on certain drugs to help her get through the day, and I totally am not against drugs. All I'm saying is it just seems that there's another drug to become dependent on, and that also creates another cycle of profit. So I just wanted to make that one comment.
Yeah.
Second comment I wanted to make was the fact of primary care and the stigma attached to it. So what happens if addicted people who go to these methadone programs don't have insurance? Does NYU accept those people as a primary care patient, and they're able to get all of the primary care, offered, whatever's offered. I think a lot of times people tend to go to these methadone programs because maybe, I'm not sure, is it funded publicly? Is it funded federally? Or do they need insurance as well? So that was the question that I wanted to ask about the whole primary care stigma.
Yeah. In regard to your first question, well, in regard to your second question, let's do the second question. I lost the first question, but we'll come back to it. So methadone programs can be public or private, and some patients will self-pay for that because it may be cheaper to buy the methadone than it is, or to partake in a methadone program than to buy $100 of heroin a day. Now, so for patients who are able to obtain insurance, they can certainly come in for primary care, and they should, and we can try to get them on the buprenorphine and get the insurance paying for it, which I think is the most just way to proceed. For people who don't have insurance, who cannot get insurance because of their immigration status, we're a federally qualified health center, and we will absolutely provide care for them. They pay on a sliding scale based on their income, and this is sort of the purpose of federally qualified health centers in our country, and one of the reasons I'm sort of proud to work in one. But getting them the buprenorphine is a challenge because it's about $4 a tablet if people are paying out of pocket. So you can imagine 30 tablets for the month would be $120 for somebody paying out of pocket. So I will say that situation really doesn't happen very much. I don't see too many patients who are self-pay for buprenorphine. I see a lot of patients who are self-pay for diabetes and hypertension and sort of run-of-the-mill things. So maybe that answers that for you, Jill. Is that okay?
Yeah, but I'm just, because the woman who spoke previously, I'm sorry I forgot her name, she was just talking to the fact that, there's a stigma attached to the methadone program. And I just think that, well, if you don't have insurance and you're not able to get this particular drug that you're speaking of, then then here we go again about, people who have and who don't have. So the ones who have insurance can get this drug that you're speaking of, but the people who don't have insurance might not be able to get that drug. So, I was just concerned about that.
I share your concern. It's a flawed medical system.
Yes, it is.
I mean, if you want to derail this call,
No,
we can talk a little bit about how to fix the American healthcare system. I mean, I'll just divulge that, I think there should be much more public financing of it, but I don't want to blow up the call. So, but for that very reason of equity and equal access.
All right. I sort of being mindful of time, and I want to give you the time you may need to finish up if there's anything more in your presentation.
Oh, yeah. Well, I can't ignore Dr. Ramawi because he's been raising his hand so patiently, and I know him. I think he's raising his hand. Maybe I'm making his head hurt. I can't tell.
Yes, Dr. Ramawi?
You're gonna have to unmute, my friend.
You're on mute.
You hear me now?
Yeah, we got you.
Okay, I just want to draw attention to the spiritual point of view in the treatment. Because if you raise your kid good, if we speak to the schools and we speak to the religious places and we speak to the youth centers, how to raise the child and how to bring him up. First of all, he will not go to the drugs. Number two, if he is on drugs, he will accept the treatment. And if he is treated, he will not go back to it. So we always concentrate on the medical treatment, how to give Suboxone, how to give all these things, but we don't concentrate on the spiritual point of view, which in my belief is very effective. That's my question.
I think it's a really good point, Kazama. And the truth is that, so first of all, everybody's different, and some patients respond remarkably well to spiritual treatments. Not all, but some. And if we're not exploring that with patients, we're doing them a disservice. Similarly, 12-step programs, things like
Yes.
Alcoholics Anonymous or Narcotics Anonymous. These
Yeah.
are traditionally very spiritual groups. They say you don't have control of the use of the drug, so turn the control over to a higher power
Right.
and work your way through it that way. And what we know is that those interventions work very well for some people, and they are ubiquitous and they are free. So
Yes.
if we haven't allowed people to connect with those, we're not doing due service. But there's a big qualifier on that. For people for whom it doesn't work, there's no evidence that forcing people to go to a spiritual program or a 12-step program improves their outcome, because not everybody likes it, and not everybody likes to share their story. And not everybody, frankly, is spiritual. Some people are and some people aren't. And so I'm really glad that Dr. O'Malley made that point. 12-step programs really should be part of the services that we can offer, but probably should not be mandatory. So conscious of the time. I see Lori. Go ahead, Lori.
I just wanted to just make one statement.
Sure.
I think that, regardless, I mean, there are a lot of problems with, the healthcare system, and we may not ever get to the, the causation of why this, some people find themselves in the grips of this and some people just don't. They just aren't inclined that way at all, as part of their makeup. I just want to say that I am really glad that they have these treatments. A friend of mine, her son passed away just recently, and he struggled with addiction for so long, and he died of an overdose. So I'm just so happy that these drugs are out here and some people can continue to live their lives on them. So
Yeah.
I'm sorry for that, but I just wanted to add that, and I want to thank you for the presentation you made. So that if people aren't aware of these therapies, that maybe they are now.
Thank you, Laura. So sorry for your loss.
Yeah, Lori, thank you for sharing that. And I think that this is where the stigma really matters, because nowadays everybody knows somebody who had a family member who just, and the families don't even want to share it. They don't want to talk about it. It's shameful. And diabetes isn't shameful. Blood pressure isn't shameful. So why is it that the drug use is shameful? And how is that shame that's associated with it making it hard for people to get treatment? So I know it's time. I've been talking about some of these numbers. I just want to try to show them. So this is a study that was done by SORTA, a meta-analysis, a large number of studies put together. And you say, okay, if people are in treatment, how many lives get saved? And so on the right side, this is how many lives get saved by the heart medicine Lipitor, atorvastatin, after a heart attack. If you treat 100 people for 10 years, you save 2 people. So if you treat 100 people with buprenorphine for 10 years, you save 5 of them. And with methadone, it's substantially more. If 100 people stay on a methadone program, 25 of them probably end up not dying. And I want to try to show you why that is. So by the time people seek methadone, they have really severe opioid use disorder. And so once people start on methadone, if they then come off the program, if you have 100 people, the people in red are people who will die over 10 years. And you see, when people approach Suboxone or buprenorphine, they're not as sick yet. They're still functioning at a higher level. So if you look at everybody who starts buprenorphine and comes off of it, this is how many die. But if those people stay in treatment over 10 years, the green people in the diagram are the number who are saved by it. And so I always worry that people are like, oh my God, methadone is so much better than buprenorphine. And that's not exactly what I'm saying. But what I'm trying to illustrate is buprenorphine is the medium strength therapy and probably should be the first thing we offer people. And methadone is the stronger therapy and should probably be the thing we offer to people who don't thrive on buprenorphine. And I hope that sort of, if we couple the statistics, which are kind of dry, with the story that Lori, sort of profoundly told for us, I think that's the story. So I think that's probably a good place to leave it. I encourage you all, if you know somebody, either a family or a family member who either needs help or knows somebody who needs help, please do share April's number. You know, we're happy to also, like, we don't always keep everybody in-house. We sometimes refer them around Brooklyn too. We have like referral relationships with other programs, Bridge Back to Life, Resource Counseling Center, Realization Center, and local methadone programs. So, you know, we can try to help people and meet them wherever they're at.
Thank you. Thank you very much, Dr. Corso. That was an excellent presentation. Iris,
I was just about to say the same thing. Dr. Corso, thank you very much. It was excellent. You gave us so much information, and we're so glad to have you in the community and available to those who need you.
The positive piece that was missing is I usually call a patient. I couldn't find one for tonight, but it's really fun to talk to the patients about it, because the patients who are in treatment, like, they're just like, I take this medicine, and then can I go now? I gotta, you know, pick up my kids. I gotta get to work. I gotta do my thing. So it's really fun. And my last thought is, you know, when's the last time that a patient came up to you and was like, "Oh, doc, thank you so much for that blood pressure medicine. Doc, oh my God, that cholesterol medicine, that is just, that's the best." But when you work with people with opioid use disorder, when you put them on buprenorphine, they come to you, they're like, "Doc, you're saving my life. Like, this is really better. And thank you." And like, it's easy. You're doing all the work. Iris, thank you for the opportunity. April, thanks for coming out.
Thank you very much. Thank you.
all right, thank
Talk to
you.
all soon. Thanks for the chance.
Thank you.
All right, so unless there's anything else that anyone to bring up, we can convene.
Adjourn.
And adjourn is my brain at this
Adjourn.
point.
I just had a quick question.
Okay,
I'm sorry. I just, I've been listening the whole time, but so this was presented to us, right? To everybody in the, the community board, and I guess there was some other people on, not so many. What are we doing as a community board, or is this going to be presented to other people in the community? Are you going to have, maybe the doctor said, he loves when the patients come on? Are the patients going to go and speak to other people in the community, maybe who also have issues, that they can relate to them to help them? What was the goal of,
So
this
Jill,
meeting?
I just wanted to share with you, this is informational, and we did reach out to every community organization, school, house of worship within the district. The reason why we put this on YouTube is it will be shareable. We hope to talk about some future work of the board, in future meetings. Maybe Iris, that's something we could talk about. We've worked on different issues. We have in the office, we have referrals for those who come in with a lot of information that we've learned over the last few sessions, and this certainly is one of them. Our vape forum had about 800 views, and it was shared and used at different assemblies throughout the district, school assemblies. So we do appreciate and actually grateful for this format, because we are able to save it and share it for those who are interested in the community.
Hey, Joe, maybe we could put something on our webpage also.
Yes.
Just like, if you have a problem, whatever, so something very, short.
And then if you
And
give
our
it to me in
newsletter.
shareable format, I'll share it.
Yes. Okay, great. Thank you.
Josephine, I just want to add that if you know of any organization, community-based organization or otherwise, Dr. Corso will make time in his schedule to do this presentation again.
thank you.
That's true. Thank you, Sarah.
That's what I'm here for.
Yeah.
Technical
you.
issues.
Josephine, if you recorded this lecture, which he gave, can you please send it to me, email it to me if you don't mind?
Yes, I will. I will do that.
Sarah
Thank
also
you, my
pointed
dear.
out,
Thank you.
I made an error a few minutes, like 20 minutes ago, about alcohol. So in most states, although I think not in Louisiana, the drinking age is 21. Although I think in at least Louisiana, I think it's 18. But in any event, 21. But you get the idea.
Yes. Thank you.
I was just poking fun, Dr. Corso.
No, and gotta mean what you say and say what you mean. So thank you for that.
Thank you.
Thanks, guys.
Thank you, everyone.
Thank you. Thank you.
Thanks, everybody. Good night.
Good night, everybody.
Bye.